Okay, here we go with the acid-base lecture for early on paramedic class. Acid-base, super important. It's one of the big things that we start to learn in the advanced EMT portion of the class. And a lot of people believe that acid-base is one of the most difficult aspects of teaching and learning uh, the the curriculum for paramedic. And boy, oh boy, I just don't think that's true. This is not difficult to learn. First, you have to convince your brain of that. This is easy stuff. Second, it is important for you to learn. Although we don't always get the facts and figures that we talk about as far as blood levels and things of that sort, it's important for us as paramedics to understand what's going on in the body. When we understand what's going on, it makes our treatment just make sense. And instead of having to memorize things, then you can just understand things and you'll be much better at critical thinking. First of all, when we're talking about pH, what we're really dealing with is hydrogen. The old big H in pH is hydrogen. And some things are labeled as either acidic or alkalytic. And that depends on whether they are going to release hydrogen ions or accept hydrogen ions. And we use pH as the way of expressing that. Acidic chemicals or acidic substances tend to release hydrogen. For an example, that stomach acid, hydrochloric acid, when we break that apart, it gives you hydrogen and chloride ions. On the opposite side, the alkali is something that's going to accept hydrogen ions. So the big one for us, as we'll talk about endlessly, is bicarbonate. Bicarbonate accepts hydrogen ions to make a very weak acid called carbonic acid. Big part of what we're going to be talking about today. So our body, I'm going to say this probably 3 times or more during the presentation, our body has to maintain a pH range, all right? It really isn't dependent on, or I'll say it doesn't really care what our CO2 levels are or what our bicarb levels are. What matters most is the pH level. And when the pH level goes out of the normal range, we immediately start to see consequences. Our brain does not work as well. Tissue starts doing things that we don't want it to do, like releasing potassium out of the cells and things of that sort. So when we're talking about acidic, that has a low pH, all right? Something acidic has a low pH. When something wants to donate hydrogen, right? It wants to give hydrogen. It has a low pH. The scale goes from 0 to 14. So 7.0 is going to be in the middle. Distilled water is about a 7.0. You could then say, if you wanted to, anything below 7.0 would be kind of thought of as acidic. Things above 7.0 would be thought of as alkalytic. The difference between 7.0 and 8.0 is a matter of 10 times. All right, so they call this a negative logarithmic value. Negative logarithmic value. The negative side is when we talk about it wanting to donate H. A lot of people will say there's a lot of hydrogen there, right? There's a lot of hydrogen. When you say there's a lot of hydrogen, when there's a bunch of hydrogen, that is a low pH. When you are going to accept a bunch of hydrogen, accept, that goes to being a increased pH. A logarithmic value isn't a 1-for-1 thing, it's 10 times. So the difference between 7.0 and 8.0 is 10 times. Our understanding of pH and corrosiveness and acid and alkali, we already kind of figured this out. You know, we had talked about this probably when we were in high school, and we see things, whether it's in a movie like Fight Club, or we're just looking at different things like bleach or ammonia, household items, just in normal things. We'll see some of these things. We've heard of the term, here's a whole bunch of terms really that we've heard of before. Things like battery acid, baking soda, the idea of citrus fruits being acidic, stomach acid, I'm sure you've heard before. Tomatoes are acidic. Soap, especially from the very beginning of what we would recognize as soap, that's made from lye. A lot of people have heard that term before, and they know lye is very alkalytic. So let's look at these list of stuff that's on this slide and take a moment, stop the video for short, and then try to put these things in order from a pH of 0 to a pH of 7.0. And where would you think this stuff would be? You kind of probably are thinking, well, coffee. I've heard people talk about that upsetting their stomach, and I think that's acidic. So, but it can't be too acidic. It's not battery acid. So where would you think battery acid would be on that? Where's stomach acid? Lemons, coffee. Where do you think all of that kind of stuff is? Tomato, that would be, I believe that would be on the acidic side. And then what about the alkalosis side? Where is antacid medication compared to drain cleaners and bleaches and things of that sort? So take a moment, stop the thing. Really, you probably should do this. You start to get it a little bit better when you start to appreciate pH, get that foundation. And then this is what you should come up with. Battery acid is way at the end there, but something that is amazing to me is that stomach acid is right next to it. It is really amazing that we don't run into ulcers more often. We just have, the secretion of mucus that protects the gut from a hole getting burned in it because we have hydrochloric acid always in our stomach. Here you see some of the other things like lemon and vinegar, tomato, coffee, all of those on the acidic side. You see their blood is 7.35 to 7.45. That'll be on a later slide. And then you see their baking soda, stomach tablets, which is the antacids, ammonia, soap, bleach, and then drain cleaner, all very on the alkali side. And so when we're talking about pH, we're really talking about hydrogen ions. A normal pH in our body is 7.35 to 7.45, and our body wants it to stay that way. We do not react very well when our pH goes low, below 7.35, and that's an acid, or when it starts to go up above 7.45, like an alkali or alkalosis. In order for us to keep our pH in between 7.35 and 7.45, we have some what you would call compensatory mechanisms. And the first one is our bicarbonate carbonic acid buffer system. Bicarbonate carbonic acid buffer system. And this basically consists of us having a bunch of bicarb in our body. Our bicarb should be at like a 20-to-1 ratio. 20 bicarb ions hanging out in the blood, ready to go. And as soon as we have hydrogen then, and hydrogen is acid, the terms should be almost synonymous in your brain. Hydrogen is acid, acid is hydrogen. All right, kind of think of those two together. So when we release hydrogen from the tissue or from a cellular metabolism, we'll have bicarbonate right there, and those two will connect and form carbonic acid. That's right in the middle there, H2CO3. And then as that heads to the lungs, it will, as long as there's an enzyme called carbonic anhydrase, it will change into water and CO2. Both of those we know, right? Easy for us, our body to manipulate. We just breathe off the CO2, we can breathe off the water, we can manipulate or deal with water really well in our body. So instead of having hydrogen, we get H2O and CO2, and we just deal with that very well. the lungs and the kidneys are going to support the bicarbonate carbonic acid equation that we have there. So hydrogen ions combined with that bicarbonate forming a carbonic acid, they break down into CO2, right? I always put CO2 at the end of that equation. So the CO2 we breathe off. So the way our lungs help us compensate is we breathe off that CO2. And we know that our CO2, hopefully we know, because we know our end-tidal CO2 values now, are always supposed to be between 35 and 45. So that is like, we've talked about how CO2 causes us to breathe faster. We talked about it even in the EMT class at the beginning of talking about the hypoxic drive. So the lungs help us compensate by kind of recalibrating the numbers there. Instead of making our normal 35 to 45, it'll drop it to whatever it needs to be. If we are really acidic, we're building up a lot of hydrogen. Remember that hydrogen will combine with bicarbonate. Bicarbonate will become carbonic acid. Carbonic acid, H2O, and CO2. And CO2 goes up, we'll breathe faster. Happens all the time. And so when we have that continued increased amount of CO2 and our cerebrospinal fluid starts to change towards the acidic nature, then our body will say, you know what, let's breathe off even more CO2. All right, let's recalibrate that. Instead of saying normal is 35 to 45, let's calibrate it down to 30. And we're going to then breathe fast, continue to breathe fast until our PaCO2 is down to 30. So that will help us maintain our pH. The kidneys also help, and the kidneys help by recovering the bicarbonate ion or excreting hydrogen ions. That's kind of easy stuff. We can just learn it as that right now. Later on, we'll talk more about this in the GU chapter, and we'll cover the kidney a lot better. But right now, we should just recognize the kidneys are filters. They help us excrete different ions. And when we are using our kidneys to help us with acid base, they could recover bicarbonate ions. Let's say that we were really acidic for whatever reason. Well, our body will start to recover the bicarbonate ions. Recover, that means we will keep our bicarb instead of peeing it out. And the same thing with excreting hydrogen then. We're really acidic, well, let's pee off some hydrogen. And then you know that this is occurring. A lot of people are familiar with this because they know that people will sometimes be asked to pee on a pH stick to check the levels of acid in their urine. We can also excrete ammonia ions. We're not going to talk much about that, but ammonia has a lot to do with intracellular acid base. And before, when we were talking about the lungs help us right away. They can kick in, I think you could say, within seconds of having an increased hydrogen / increased amount of CO2 in our body. But the kidneys are going to take longer. All right, they're going to kick in like an hour, and then but the kidneys can last for days. All right, they can keep on recovering that bicarb or excreting the hydrogen. They can do that for days. For us trying to use our lungs to help us compensate, the lungs will end up getting exhausted at some point. So it's good it's going to kick in right away, but it's probably only good for hours. And so here's our normal blood values. This is going to be quiz material. We're going to see these a lot. You might as well memorize it right away. Hopefully the first two you got down pretty well already. 7.35 to 7.45 is the normal pH. 35 to 45 for CO2, and our bicarb, you'll see all kinds of different numbers for this. I think our book says 22 to 26. I usually widen that range to 22 to 28. I've seen things say 21 to 29. Really, when we're writing these out in quizzes, I'll take almost anything in the 20s. I'll recognize that as just to be a correct answer. And remember, when we're looking at these, the body doesn't care about PaCO2 and HCO3 levels, all right? It cares about the pH. So it will manipulate the other ones to allow us to have a pH that stays between 7.35 and 7.45. When we're looking at those PaCO2, we can see that that is associated with the lungs. So when we're talking about the compensatory part of this, PaCO2 goes with the lungs, and that HCO3 goes with the kidneys. All right, our kidneys are going to manipulate that. And so here we have that equation back on the top, and then just a little bit of a review here. Any condition that increases carbonic acid or decreases bicarb, in one word, what would you say that it is? It increases carbonic acid. A little bit of help is acid there. That would give us an acidosis. You might see this as acidemia also. And acidemia means in the blood. So acidosis is kind of the body overall, and acidemia is the blood, and that should be the same. We can just think of that as the same. And so any condition that increases bicarb, since bicarb is a base, or base is alkalosis, and decrease carbonic acid, it decreases acid, we're going to call that alkalosis. Pretty easy stuff, all right? Pretty easy stuff. A metabolic disturbance will affect the HCO3. And maybe a better way to say that is the bottom thing where it says respiratory disturbances. Respiratory disturbance will affect the PaCO2, right? Because our lungs manipulate the CO2. The metabolic, everything else, if it doesn't have anything to do with the lungs having a problem, well, then it's metabolic, all right? So here we go with some respiratory acidosis stuff. Maybe it'll start to make sense here. Respiratory acidosis is caused by a retention of CO2. So a retention of CO2, we bump back to that, well, what was normal on CO2? It was 35 to 45. So if we were looking at blood values, the CO2, the PaCO2 in the arterial blood gas is going to be above 45. So what do you think would cause you to have an increase in CO2? All right, what would cause us not to breathe well? All of those things are what cause respiratory acidosis. So you can take a moment, you can push the pause button if you want on the video. What causes you to have respiratory acidosis? And it's all hopefully things that you understand. These are all like the headings in the respiratory chapter, plus a few extra ones. So you have asthma, both of the COPDs, pulmonary emboli, pulmonary edema and CHF, pneumonia, pleural effusion, all of the things in the respiratory chapter. All right, so that would be foreign body airway obstruction from the very bottom there. But other things, all the traumas to the chest, a broken rib can do it, flail chest, a pneumo, a spontaneous pneumo, as well as a traumatic pneumo, a tension pneumo, a hemothorax, all of those. And then respiratory depression from a head injury or a stroke. And then all of those bad respiratory patterns that are causing you not to breathe very well. And then respiratory depression from drugs. And so this one is the one that kind of confuses people. You can't just say overdose, because some overdoses are going to cause a metabolic acidosis. Some overdoses will cause a metabolic alkalosis. An overdose that decreases your motivation to drive, central nervous system depressants, those are the ones that can cause a respiratory acidosis. So that would be narcotics, benzodiazepines, and alcohol. All of those are central nervous system depressants. And then how would you treat respiratory acidosis? You treat what you see, all right? You treat the underlying cause. You treat asthma as asthma, and I could say that for each of those different things. We don't treat respiratory acidosis, we treat the patient, all right? So, and that is whatever that primary complaint is, and then we will. So let's relate this back to that equation that we talked about before, the bicarbonate carbonic acid equation. You'd call this a formula. Before the slide, just called it the buffer system. It's the primary way that we handle acid base in our body. And here what we have is I took what was on the right side of the equation before, and now it's on the left. You see that arrow that goes both ways between water and carbonic acid. That would mean that the equation can go both ways. So we could put CO2 and water on the left side of the equation if we wanted to. So we have carbon dioxide there. That's always going to, in our body, attach itself to a water molecule and give us carbonic acid. And so anything that causes us to increase the amount of CO2 in our body, asthma, foreign body airway obstruction, whatever it would be, that CO2 is going to attach itself to a molecule of water, give us carbonic acid, and that is going to make us acidic. All right? So anything that causes us to retain CO2, that drug overdose where we're not breathing very well, that will cause our bodies to have an increased amount of acid. And when we're talking about an increased amount of acid, the way we may express that is a low pH. Another way to think about it is we have a bunch of hydrogen in our body that's available. Fix the acidosis as we take care of them. So if respiratory acidosis was the retention of CO2, respiratory alkalosis is going to be eliminating all of your CO2. So if you think about it, how do those hyperventilation syndrome patients look? You know, they're breathing fast, breathing deep. The only problem with hyperventilation syndrome is the CO2 is gone. All right, it has nothing to do with oxygen. So as they blow off all of their CO2, that will, I like to say it this way, that will push the equation the other way. Remember that equation that was H plus HCO3, H2CO3 in the middle there, and then water and CO2. CO2 is way over there on the right. Well, when our CO2 goes way down, it's going to cause things to happen. All right, and that is respiratory alkalosis. All right, so it'll cause an alkalosis. And when we are alkalytic, our calcium will be displaced. That's why we continue to have those after a while of hyperventilation. We have some of those problems with spasms and such. It's because your calcium levels that ends up being an electrolyte imbalance. So usually when I think of respiratory alkalosis, I go right to hyperventilation syndrome. But remember, that could be a head injury too, if the head injury caused central nervous system hyperventilation. All right. So it could also be medications that just cause you to breathe really fast. All right. If a medication causes you to breathe really fast, and I'll tell you, that's never an answer on a quiz. Neither one of these are answers on quizzes. It just is a little bit too confusing to throw them in as answers on quizzes. So you should be thinking it's almost always the hyperventilation syndrome. But later on, as we get into real big critical thinking type of things, it could also be high altitude. All right, because at high, there's this thing called HAPE, high altitude cerebral edema, or that's HACE, high altitude pulmonary edema, HAPE. Those things can also lead you to having respiratory alkalosis. So here we are back to that buffer equation. We have our carbon dioxide and water equal carbonic acid. When we talked about the respiratory acidosis, we increased CO2. Now we're talking about decreasing that CO2. We'll still affect the equation going this way, but here we're going to decrease the amount of carbonic acid. So if we decrease acid, we express that as alkalosis. Decreased acid equals alkalosis. That makes sense. But anything that causes us to blow off our CO2 will cause our bodies to become alkalytic. And another way to say that, using those other terms, is an increase in pH could also be expressed as a decreased amount of hydrogen that's available. And what we talk about then is we have an increased amount of HCO3 that would be available too. All right. And then there's metabolic alkalosis, and really my favorite one for metabolic alkalosis is an overdose on something like tums. All right, you overdosed on antacids, something like that. The other ones are, they throw diuretics in there. If you think about vomiting, if you're continuously vomiting out your hydrochloric acid, that is your gastric contents, has gastric juices, you've made those, they're very acidic. So when you throw them up, your body is going to make more, and then you throw it up and your body's going to make more, and you throw that up and your body's going to make more, and pretty soon you're going to tend towards being alkalytic. And so, but I don't talk about that much. You're not going to see it on quizzes here. It is a possibility that is the problem, though. They threw up too much acid, and now they're in a metabolic. So again, let's relate this back to the bicarbonate carbonic acid buffer equation. Here we're going to go back to kind of way we saw it at first with bicarbonate plus hydrogen will give us carbonic acid. So in this first example, when we're talking about metabolic alkalosis, we increased the amount of bicarbonate in our body. And as students, we should just always, just immediately when we're talking about this, just associate it with this is when somebody overdosed on bicarbonate, overdosed on Mylanta or Tums, something like that. They took too much bicarbonate. That's going to push this equation this way. And the thing is that this is a little bit confusing, but it's going to decrease the amount of carbonic acid. So that could be confusing to some, but let's just use our common sense here. When we eat too much of an antacid, we're going to have a low amount of acid. We took too much anti-acid, we'll have low acid. So if we know that bicarb absorbs hydrogen, that if we overdose on bicarb, we'll absorb too much hydrogen, and that is going to then cause a decrease in acid, and we express that as alkalosis. So here, anything that causes us to have an increase in bicarbonate, usually what we're talking about is overdosing on bicarbonate. That will cause the hydrogens to be absorbed, decreasing the free hydrogen, and that causes alkalosis. Remember, alkalosis is an increased pH. It's also a decreased hydrogen, alkalosis. And then the next thing is metabolic acidosis. All right, metabolic acidosis, and metabolic acidosis has a few causes. And again, this is going to be, we're going to have a lot of discussions. We're going to have a lot of quiz questions. Respiratory acidosis can be from, I'm going to go with DKA first. You know, DKA is a great example of that because we see that DKA patient and we immediately think of small respirations, which are fast and deep respirations. And then now that we're in the advanced EMT portion, we can not only talk about memorizing small respirations as being part of DKA, which is maybe how you learned it as an EMT. Now we can say the patient in DKA is obviously going to breathe faster and deeper because that is the compensatory mechanism that they're going to use. They're going to recalibrate how their normal levels of CO2, and they're going to breathe faster to compensate for their acidosis. Other things that are tied to acidosis is ingestions of toxins if those toxins have an acidic nature to them. So aspirin is acetylsalicylic acid. So when you eat too much aspirin, that causes a metabolic acidosis. We'll talk about methanol in a way that can end up in when we get to toxicology. We'll talk about it a lot more. But methanol ends up giving you a metabolic acidosis. Renal failure and acidosis go together, and it is a metabolic acidosis. And then lactic acid. So whenever you're in an anaerobic metabolism, so that would include shock, that is a metabolic acidosis. And then how do we treat, how do we treat metabolic alkalosis? How do we treat metabolic acidosis? All of these, we're going to treat the patient, treat the patient, treat the patient. For all of these, it's basic concepts, basic stuff as an advanced EMT. We're not talking about giving them any drugs to treat these things. We treat the cause, all right? And that's what we're going to do for a while, all right? Just treat the cause, treat the airway, treat the breathing, treat those kind of things. Most of the time, the actual treatment for the acidosis or alkalosis is going to be in hospital, all right? We will talk about it a little bit more when we get to. All right, last time I have to say this, we're going to go back to the equation. And here, again, we're on the, from the original one, we're on the left side of the equation where we were taking hydrogen and adding bicarbonate and getting carbonic acid. So here, anything that increases the amount of hydrogen in our body. We've talked about DKA. That's a great example to go to because it relates us right to, something that we learned as an EMT. Maybe you've seen patients with DKA so far, but it's also shock. An aspirin overdose is also a great one. An aspirin overdose. Aspirin is acetylsalicylic acid, so it's easy. You've overdosed on aspirin, which is an acid. So that's going to push this equation this way, and we go back to the easy stuff then. Increased hydrogen is increased acid. Hydrogen is acid, so we increase hydrogen, we will increase acid. And our axiom here is any non-respiratory issue that causes us to have too much hydrogen, when we know hydrogen is acid, right? So we will have metabolic acidosis because our body's going to eat up the bicarb that we have available, decrease the amount of bicarb by eating it up, by attaching it to himself and getting carbonic acid. So any non-respiratory issue is going to be giving you a metabolic acidosis. And remember, low pH equals increased hydrogen. Paramedic. So here's the acid-base matrix, and you're going to see me talk about this a lot. This is going to be huge for your quiz grades right away. We're going to start seeing them as extra credit, filling the whole thing out, and then it will be quizzes on, we'll have speed quizzes where you're just filling these out and along with the normal values and everything. So it behooves you to get this right away. You'll start to get extra credit right away and you'll do much better here. All right, so this is a cheat sheet. You want to be writing this out with confidence. So when you get to the National Registry and they give you that little whiteboard and pen to use, you will write this out right away. All right, if you write this out along with some more stuff, when you get to acid-base questions are easy. I write these out, and when I'm taking the National Registry or a formative or summative evaluation that I want to do really well on, I am going to write this out and I'll get the question correct every time. All right, so what this is basically saying is if you look across the top, those two columns are acid and base, right? Acidemia, like I said before, that's the acid levels in the blood, and alkalemia, acid levels in the blood. I'm sorry, alkali levels in the blood. It's basically a measure of pH, right? Acid and alkalemia is a measure of pH. So when we go down that column and we're looking at acidemia, we know that the pH is going to be below 7.35. All right, alkalemia, the pH is going to be above 7.45. So you just write those in. When we're talking about a respiratory acidosis, that's the box that we have there. Respiratory acidosis is going to be a retention of CO2. For some reason, they're not breathing. That you can name any of those breathing problems that we had up there. Asthma, we'll go with asthma, all right? So he is not breathing well, all right? He's not ventilating well through spasms, secretions, and swellings. So if he's not breathing well, We're not talking about oxygen, we're talking about CO2. He's not blowing off his CO2, he's retaining his CO2. So his levels of CO2 in his body are going to go up. That's the primary problem that happens when you have a respiratory acidosis problem. When we go to respiratory alkalosis, we know that that's really tied with one thing, hyperventilation syndrome. So with hyperventilation syndrome, he's breathing too fast and deep, so he's going to blow off his acid. He's going to have a low PaCO2. In both of those, his bicarb level should be normal, at least at the beginning. And so metabolic acidemia. So we're in the acidemia column, and it's metabolic now. So we got the pH right. It's not a respiratory problem, so the PaCO2 is going to be normal. And then the bicarb is base, bicarb is alkalytic. So we should realize right away that metabolic is going to be below 22. All right, it's going to be below 22. And the way we got there was he had DKA. And during DKA, he ends up with its diabetic ketoacidosis for a metabolic problem. He had produced too much H. When you produce too much H, it's going to start eating up a bunch of those bicarb, and your bicarb levels are going to go low. And then the next one, again, I almost always associate this with a overdose on tums or Mylanta or any antacid that you want to think about. Normal antacid, not the H2 blockers. Remember, we saw this as diuretics also have a tendency to do this. And then here we have our pH goes up because it's alkalosis. Our PaCO2 is going to be normal because it's not a breathing problem. And our HCO3 went up. Why? Because we ate a bunch. All right, we ate a bunch of bicarb. Again, here we have that it says 26 milliequivalents, and I like to use 28 in that area too. So from there, just simple rules. All right, when we're looking at acidosis, it's always a low pH. When we're looking at alkalosis, it's always a high pH. A respiratory problem will be a problem with CO2, and a metabolic problem will be a problem with bicarb. Easy stuff, easy cheesy. So here we go, just a different way of seeing the same things, all right? And then we're going to talk a little bit more about compensation here. Here, when we have a metabolic acidosis, the first thing that's going to be the problem, the first alteration that we have is going to be the HCO3 is going to be low. How did we do that? I just explained it. All right. Your DKA, you produce too much hydrogen. Your hydrogen is going to associate with bicarb, and you're ultimately, as that continues to happen, your bicarb is going to go low. And so what your body will do to compensate for that is it will lower your CO2. All right, it'll lower your CO2. So how does our body lower the CO2? We hyperventilate. Perfect example in Kussmaul respirations. All right, perfect example if you think about it that way. When we're in a metabolic alkalosis, how do we get that way? We ate too much tums. All right, we ate too much tums. We're going to do the opposite thing for the compensation. Now we're going to increase CO2. How would we do that? It's opposite day. So we're going to hypoventilate. So we should expect when we see somebody who's overdosed on Mylanta, they will present with a decreased respiratory effort. And they'll still be maybe a little bit normal looking at first. All right. So as far as they might not like have that look of shortness of breath or whatever, they will end up having a low oxygen level. It tends that way, right? We breathe according to how our chemoreceptors are sensing the CO2. So when we go to respiratory acidosis, the first alteration was an increased CO2. Well, why did that happen? For any number of reasons from that slide. We can go with pulmonary emboli this time if you want. If we have a pulmonary emboli, we're not going to be able to breathe off our CO2, so the CO2 will increase in our body. our body's compensation, which will take a little while, will be to increase the amount of bicarb. That makes sense, right? We're acidic, so let's retain our bicarb, and that will help get things corrected. So we will increase the amount of hydrogen that we pee out, and we will increase the amount that we reabsorb of the bicarb. And that would totally make sense. So here in this last one, we have respiratory alkalosis. We hyperventilated. Again, this is going to kind of be associated with maybe something like that head injury with hyperventilating, or someone at altitude who has high altitude pulmonary edema. It might start out with that. But we would have acute mountain sickness would be another way to say that. We would compensate for that low CO2 with the low amount of bicarb. And how would we do that? It's opposite day again, suppression of acid excretion. And then we would decrease the reabsorption, or we will pee out our bicarb. And so here's our compensation. This is the same, it looks maybe a little bit different to you, but the same equation as we had before. When you've got too much hydrogen, our lungs are going to blow off CO2. And I mentioned this before, that I push the equation or pull the equation. So too much of this, I like to say, pushes the equation this way, and then we end up with too much of this. All right. When you can't blow CO2, kidneys try to get rid of hydrogen. So when you can't get rid of this, it's going to go that way. Kidneys are going to try and get rid of that. After a while of compensation, both of the lab values will be off their mark. So far we've really talked a little bit about primary and secondary. All right, the secondary is our partial compensation. All right, we're partially compensating, so our pH is not going to be fixed yet. And remember, the body doesn't care about CO2 and HCO3, doesn't care about CO2 and bicarb. It cares about the pH. So when we're talking about partial compensation, this is the way it ends up looking. We have, again, when we look at the acidemia column, pH is going to be low, and the alkalemia column, pH is going to be up. When we first did this, if we look at just the black arrows, respiratory acidosis was the increased PaCO2. Alkalemia, respiratory alkalemia, was decreased PaCO2. And metabolic was, for acidemia, a low amount of bicarb, and alkalemia, it was a high amount of bicarb because we ate too much of it. And then we compensate. So we see on the bottom of the slide, this is partial compensation, and the red arrows will be how we partially compensate. So after a while, we'll start to do this. Our HCO3 will go up for respiratory acidosis. Our HCO3 will go down for respiratory alkalemia. Notice there, when we're just doing our cheat sheets, the arrow goes the same way. It goes the same way in all of the boxes. All right. So what I mean by that is, if we go to metabolic acidemia, the bicarb arrow went down, so the PaCO2 arrow is going to go down. When we had metabolic alkalemia, how did we get that way? We ate too much Mylanta. Because we ate too much, now our bicarb level's up, and when we look at the way we compensate, our PaCO2 is going to go up. The second arrows are always up. So again, writing out cheat sheets, super easy. This is, this is Sesame Street kind of stuff. And I very often will say that, but it is this easy. All right. When we're compensating, the other value is going to follow the same arrow as the first value. And then when we're fully compensated, those arrows are going to stay the same. The only thing that changed on this slide is we're fully compensated, and our body only cares about the it only cares about the pH. So now our pH is back to normal. Arrows are all the same. So here we have just a few case reviews. First one, 31-year-old woman having an asthma attack. She's short of breath for about 90 minutes. Taking her albuterol a few times, no relief. So first of all, you'd have to say to yourself, what does she have? What would you say that this lady has? All right. You have four choices: respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. That's it. Those are your four choices. And so then you say to yourself, what would you expect your values to be? You'd picture the, what do you think this person would be? This is just, a pretty easy one. If we were really, we appreciated the idea that she had asthma, we would give her respiratory acidosis, and we would say her pH is going to be low then, and her PaCO2 is going to be up, and her HCO3 should be normal, in the normal range, which we were given 22 to 26 or 28. And so there we have it. That is how easy some of the questions are going to be. And we would then, as we see those values like that, we would say, boom, her acid-base derangement is primary respiratory acidosis. And so we have a 23-year-old man with dyspepsia, kind of a upset stomach kind of thing. All right. He also is drinking, and he's been vomiting, but you find an empty bottle of Tums on the coffee table. That's kind of a big clue here. Vomiting too. He's been vomiting for a while, so he's been vomiting out acid and eating alkali. So you'd say to yourself, well, I wonder what that guy's problem is. The first thing that you'd say, like, I'm hoping that this is obvious. He would be in a metabolic, because he's not having a respiratory issue, he's in a metabolic alkalosis. So what kind of values would you say? And the pH is going to be up. And his PaCO2 should be normal, right? It should be 35 to 45. And his HCO3 is going to be up, right? That's normally 22 to 26 or 28. Now it's 50. Why? Because he ate a bunch of Tums. And so that's what we would stick with for the respiratory derangement. We would call this the primary derangement, metabolic alkalosis. So what would it be if his PaCO2 was 55 though? If it was 55, that would be more than what it's supposed to be. That would be an arrow up also. So arrows up in that area, we would say to ourselves, well, that's obviously partially compensated metabolic alkalosis. Partially compensated. Here's our last one. A 50-year-old, 2-week history of not feeling well, has been urinating more than normal, always thirsty. Sounds like polyuria and polydipsia. He looks like he's dry and dehydrated, and you easily noticed fast and deep breathing. Why don't we call that Kussmaul respirations? So what would we say his problem is right off? We would say, hopefully we would say this, metabolic acidosis. He is in DKA, diabetic ketoacidosis, DKA. And so what values would you expect to see? And we would expect to see something like a low pH, acidosis. But that's not normal. We wouldn't expect that. That's what we would expect. We would expect a low bicarbonate level. We expect because he is in a metabolic acidosis that goes with a low bicarb level. So what would we call this derangement? Well, since his PaCO2 is also low, he is partially compensating. Partial compensated metabolic acidosis. And then what if his pH was 7.4, which is between 7.35 and 7.45, so that's back to normal. We would call that fully compensated acid-base derangement, or a fully compensated metabolic acidosis. And that's it. That's all there is to it. All right. You'll see multiple quiz questions, probably about every quiz that we have from now till the end of preparatory. Earlier you get the idea of these cheat sheets, easier it will be for you.